In 2019, for a study on international aid for health, medical anthropologist Meredith G. Martin interviewed a 35-year-old Tanzanian woman living with HIV. Her name is Maria, and I'm going to tell you a bit about her story. Maria is unmarried and stays in a rental apartment with her 4 children. She farms an acre of borrowed land for food and works a laborious day job for meager salary. Her family had despised her due to her HIV status. They cursed at her, said she would bankrupt them, and so she moved out to be on her own. Despite a life of poverty, stigma, and pain, there was a safety net that kept Maria afloat. In 2009, Maria became pregnant and enrolled in the Prevention of Mother-to-Child Transmission Program, or the PMTCT. Funded mostly by foreign donors, the program gave Maria free antiretroviral therapy, food, cow's milk for her child, and transportation for clinical checkups. But more than that, it gave her hope that she could raise her children and find a dignified way of living. But when Maria became pregnant again, only 2 years later, the government could no longer support her. Because of the Great Recession, bilateral aid was getting cut, and PMTCT program funding had declined immensely. Maria was now on her own. She had to walk 5 hours to the clinic with her youngest child. She had no food support. Her mental health had deteriorated. When the flow of huge amounts of international aid changed, it impacted real lives, the lives of those living at the margins of society. Tanzania has been described as donor dependent in its health sector, a phenomenon that occurs when a lower income country becomes reliant on foreign assistance for keeping up its healthcare services, its operations, and healthcare accessibility. The problem is that donor dependency is a vulnerability. Changes in donor governments, economic shocks, and transitions can all cause donor funding to decrease or be cut without any notice. And when this happens to a donor-dependent country, people like Maria, impoverished, isolated, and socially defenseless, who need donor health programs, fall into the cracks. So how can we fix this national vulnerability? Well, the first thing we need to do is improve how countries are mobilizing their own domestic resources. By using the national budget, taxes, or the private sector, countries can improve the self-sufficiency of their own health programs. The next thing we need to do is develop transition plans between donors and recipients for when foreign aid needs to decline. And finally, we need to reduce the inefficiencies and prioritize health equity in the government budget. We need to promote programs that give poorer individuals ways to earn and save money. Through focusing on distinct policy steps, we can change the narrative around donor dependency and protect the governments and people who are most devastated by it. Thank you.